Yeah, thank you, Mona. And again, thank you, Professor Gewillig, for this very intriguing presentation that you just presented. But anyway, coming back to this question, I think it depends upon what you inject and which goal you try to reach with the drug that you administer. For instance, if you use protamine, then it would be more than clear to, I think, all of us that a direct effect on pulmonary vasculature would be prominent. And therefore, a more peripheral approach would be much more favorable than injecting it directly in the pulmonary artery. Most of the vasoactive medications that we use, and for instance, looking at a potent vasoconstrictor like norepinephrine or noradrenaline, as you wish, there are some studies that if it is injected or administered directly in the atrium, so it is not available in high concentration in the pulmonary arteries, that it might decrease pulmonary, not increase furthermore pulmonary vascular resistance. Data are limited, but it seems sensible to do so. So if you have an atrial line, that it could be advantageous. However, in the end, it will mix in the complete circulation, and I doubt if it has a long-lasting effect. So, in short, it depends upon it depends upon the drug that you inject, with the purpose of the drug and its possible disadvantages when it reaches the pulmonary circulation in a high concentration before being diluted.
Yes, thank you. Thank you very much, Joost. Okay. If you could take the next question then.
Another question from the participants is an intact intraatrial septum at birth a predictor of Fontan failure? And how do you deal with it? Professor Gewillig, what is your opinion about this statement?
I think having an intact septum as a newborn is terrible. It is very, very bad because it reflects a few things. First of all, development of the pulmonary vasculature during fetal life will have been bad. I mean, if there is no adequate runoff of your pulmonary veins into your heart, the lungs will develop poorly. And sometimes not only because there is venous hypertension, but also there will be poor lymphatic drainage with lymphangiectasis from the lungs. If it's so bad that there is also lymphangiectasis of the lungs, I mean, the child will be no viable, and whatever you do, it will die because the lungs are useless. Indeed, Boulos suggests that you have to decompress that atrial septum as fast as possible. And I've heard stories of interventional guys that put in a stent as fast as possible, or surgeons that will go and resect the atrial septum as fast as possible. Sounds very heroic, very impressive, but if you go and look at that subgroup of patients 5-10 years later, I can say that many of them, I mean, usually they will end up being bad Fontans. Why? Because they have poor pulmonary vasculature to start off with, and insufficient catch-up growth. But indeed, like Dr. Boulos suggests, the first thing is decompress, get flow to the lungs, try to get as normal flow as possible through it, but you're really working with the worst end of the Fontan spectrum, because as I tried to make clear, a good Fontan is impossible without nearly perfect or better than perfect lungs. And if you're born with bad vasculature, I mean, life doesn't look good at you.
Thank you so much. And may I take the opportunity to bounce this question back to Professor Asfour, how he, as a cardiac surgeon, looks at this issue.
Well, over the many years, where I started doing Norwood operations in the mid of 90s, we have seen the one and the other. And I really do think that it depends on at what time during pregnancy the interatrial septum has closed. The ones where that has, that's my belief. I don't have data, but I do think that the ones that have had that very early during pregnancy, they typically have this very, very thickened media in their pulmonary veins. You can't do anything about that. So this is why today we would then go ahead and either cardiologists can remove the atrial septum with a Rashkind, or we would do the resection with a very short pump run and then do a hybrid procedure, because we think that a very short, either no pump run or a very short pump run is the best thing you can do, and then just wait 2 weeks, 4 weeks, 6 weeks until the resistance has dropped, and then go ahead with the stage 1. We had some good results. We tell the parents what the risk is, and that's how we deal with that today. That's what I can say.
Yes, thank you so much. Another question from the attendants is, I think, for Professor Gewillig, because he talked about supporting the circulation with an RVAD in a patient with a Fontan circulation. But could you explain more about the idea and why this is different from an LVAD then?
Okay, first of all, the applying an RVAD in a Fontan circuit is not my invention. It is the invention of God or of nature, because that's the big difference between a Fontan circuit and a normal circuit, is that you have a subpulmonary pump. Yeah. Yes, we have been playing with RVADs in the laboratory. And I think there is one commercially available nowadays in Europe from Berlin Heart. And so far, they have done 4 patients. I think they're all 4 German patients with three successes. Where they it's in some they went for a BiVAD. But it is a system so that you can pull blood from the caval veins and push it in the pulmonary vasculature. Because there's no valves, the surgeon will need to do some some new connections. It's not as simple as an LVAD. The problem with an LVAD is that you have to pull the blood through the pulmonary vasculature. Yeah, and even if you put a highly performant ventricle at the end of the lungs, if there is almost no blood going to go through the lungs, I mean, that ventricle or even the LVAD can only squeeze what it will get. And so there is some of the failures of an LVAD. I think the Americans have done a lot of LVADs, and sometimes it works and sometimes it hardly works. In the papers that I looked carefully at, frequently don't have all the data. I mean, they don't have, for instance, the data of the left atrial pressure, but it is my prejudice that if the LVAD can increase the flow through the lungs, the LVAD will have a nice result. If it doesn't work like that, for instance, if by applying the LVAD, it sucks the ventricle to a close, and so they cannot increase the suction into the left ventricle or in the systemic ventricle, the LVAD will have almost no advantage over the normal ventricle itself. The second question, part of the question there is a liver transplant. Could you do that for a fault? a liver is an organ that hates to have venous congestion. So if you put a normal liver in a Fontan circuit that has already proven to be hostile for a liver, your liver will go down the drain, I think, within hours. I mean, the patient will not survive that operation. So if the patient needs a new liver, automatically he will need a new heart. Giving a new liver to a patient, to a Fontan patient without a new heart is doomed to fail. It may have tried one, but I think nobody would do that nowadays. You transplant a heart, and if you think that the liver is unrecoverable, you add a new liver to it as well, but not the other way around.
No, I suppose so. Thank you. Mona, back to you.
Okay. Yes. A question to Dr. Cusi. One of the first questions was, what is the advantage of early extubation after Fontan? And you have really nicely shown what are the advantages of early extubation. But my question for you is, what do you do if you have hemodynamic instability after the Fontan surgery and you need nitric oxide and some inotrope and stuff like that, and you need to fill the patient continuously, so your patient is not very stable? Would you then extubate your patient early or not?
I think possibly not, because you can use also, you can give inhaled drugs to lower the pressure in the pulmonary hypertension. So I would say no, because it would not be a safe early extubation, and I think it's important to go on the safe side. So no, I would not extubate the patient if he's unstable.
Yeah, so you would then rather choose for inhaled nitric oxide and wait till the moment that the patient becomes more stable hemodynamically.
Exactly, and more independent of nitric oxide, because, we have to go gradually down and then, yeah.
Well, sorry to interrupt. I really do think that if we have a elevated PVR, we know that before the operation. So if we need nitric oxide, then there's something wrong. So if there's no saturations, either intrapulmonary shunts, or there's something wrong with the very easy created plumbing of, as Mark said, the easy operations, that plumbing is not perfect. And we have seen many of the not so perfect plumbings, unfortunately, because these Gore-Tex tubes are very stiff, and the pulmonary arteries after Glenn, they're very thin. And sometimes they are also not terribly large. And then if you have this very thick Gore-Tex compressing the LPA, then I would go directly to the cath lab and look what's wrong. Any delay in this respect, I think is not good. We have to be very aggressive, either extubate the patient or go to the cath lab.
Yeah, okay. But in any case, if you have a little bit higher pulmonary vascular resistance before the operation, you would definitely create a fenestration, wouldn't you?
Me personally, I always do a fenestration. This is what Aldo Castaneda taught me.
Okay. Yeah, because there are some centers that do not believe in fenestration anymore, but okay, that's we can do a whole other presentation over that lecture, so that's not something that we're going to discuss in detail tonight.
I think after the excellent presentation of Mark, nobody should not believe in the fenestration.
Yeah. Okay. Yes, thank you. Joost, any other questions?
Yes, maybe to continue on this matter, for Professor Asfour, as Professor Gewillig just explained, and I think we actually agree with him, that creating a Fontan circulation is actually an extracardiac operation. And however, since we need, in most instances, and as you said, actually in all instances, create a fenestration, is that achievable without support of extracorporeal circulation?
Well, I think that the advantages of doing this operation with extrapulmonary bypass, with cardiopulmonary bypass, it overweighs the disadvantages of using the bypass. It's a short run because, you can do all the dissection without it. And then you have the anastomosis. I'll start with the pulmonary artery anastomosis and then the IVC and this fenestration. So it's a quick operation, and it's, I do think if you do that in a 3-year-old 15-kilo kid, the harm of CPB is less than the risk of doing a not perfect operation. But I know there are people who are very strong defenders of doing that without bypass.
Can I make a small comment?
Sure.
I did not want to mention that you should not use bypass to make a fontan. I think if the surgeon can make his connection better and nicer and better streamlined, he should do what he feels comfortable with. The point I wanted to make is technically he can do it without a bypass, which means that he can do it without even touching the heart. And the consequences of that is that if you see that at the end of the operation, the ventricle does not squeeze very well. I mean, either the surgeon blew it completely and did give cardioplegia with chloride or whatever, or it are the secondary, the new boundary conditions for the ventricle that will determine how the ventricle will react. And that is typically the situation. You see, in the old days, and that was even, I think it was, you never saw those patients, but when we went from a double shunt to a full fontan in one operation, I have seen patients die because the ventricle was completely unloaded below its closing volume, hypertrophic like everything with no cavity inside. That was the operation that was being done in the late 80s, early 90s. Yeah.
Oh, yeah. This is terrible. Sorry, I didn't. Of course, I mean a very well prepared fontan with a good working ventricle, no or very little AV valve regurgitation, with nicely developed pulmonary arteries, with not too large, not too small shunt, and who has good pulmonary vascular resistance that goes to the fontan circulation. I don't want to be misunderstood. Thank you for explaining that, Mark.
Yeah. Gentlemen, although this is a very interesting topic, I would like to shift topics. And one of the questions from the audience is on how to anticoagulate fontan patients, and especially during pregnancy. Maybe I may ask this or forward this question to Andrea. Anticoagulation during pregnancy, how to deal with it?
It's a good question.
And especially if I may ask from the viewpoint of a anesthesiologist, how do you think about local regional anesthetic techniques in fontan patients?
Well, we usually do general anesthesia, but I exactly know that it is, if there is a good functioning fontan circulation, then regional anesthesia can be done. So, and epidural also, then they need care for the anticoagulation. So an NVH, so low molecular weight heparin, given, but should be stopped. And of course there is. So then vitamin K antagonist cannot be given during the pregnancy. But actually, what Professor De Willig, what are you advising in this case during the whole pregnancy, if any?
Well, we check our females when they want to get pregnant. We check them and make sure that there is no easy hit somewhere to improve the circuit. And most of our fontan patients will be on aspirin itself, if necessary, clopidogrel, because we don't want to put them on coumadins or things like that. But many of them will go on simple aspirin. Yeah. And it's only when they're worse, but I mean, probably we would recommend them not to become pregnant then, is that they would need to go on heparin, but I mean, that is the exception. Most of the Fontan patients we've seen and we guided through successful pregnancies were on simple aspirin by itself.
I fully agree, and there's no data that Coumadin has an advantage over aspirin, even in patients who have a fenestration. I fully agree with Mark. So we keep them on Coumadin for the first 3 to 6 months, and then aspirin. That's our strategy.
Okay. So before Mona will wrap up, there is a burning question that has been on the list for quite a while. And actually, I would like to ask this question to all speakers. And it can be answered with a yes or a no. If a vasopressor is necessary for infantile circulation patients, is there a preference for vasopressin or for over noradrenaline? So is there a preference for vasopressin over noradrenaline concerning its effects on the pulmonary vasculature? Andrea?
We still use
yes or no? Preference?
In certain cases, yes. But
certain cases. Yes. I have to go to Theophili. What's your yes or no? Vasopressin.
I would go for vasopressin instead of noradrenaline.
Professor Gewillig, from your point of view.
It will be my intensivist that will decide. Whatever I say. But I think he will go for vasopressin.
Vasopressin. And Professor Asfour, what's your opinion about this?
I would also think our intensivists would go for vasopressin because of the beneficial effects on the lymphatic system.
Okay. Well, thank you much, and I will hand over for the final wrap-up to Mona, please.
I would say that you don't need to increase the systemic vascular resistance. That's what you learned.